David Waisel is an associate professor of anesthesia at Harvard Medical School. He's the program director for the Pediatric Anesthesiology Fellowship at Children's Hospital Boston. He is an international expert in medical ethics relating to anesthesiology, having published more than 50 original papers, commentaries, and chapters. His areas of interest center on medical professionalism, informed consent, and capital punishment, which is his topic for the morning.
Good morning. First, I want to thank y'all for inviting me. This is a beautiful town. You might not realize it because you're here all the time, but I'm just overtaken by its beauty. And as he alluded to, the museums, the Railroad Museum I loved, the Gun Museum reminded me of my time in the Air Force, and well, the Car Museum I don't know enough about, so it was pretty, but I don't know. Y'all may be wondering why a pediatric anesthesiologist is interested in capital punishment. And it started, maybe. So I'm very interested in having this work. Which way do I point it? While we're waiting for that, I will tell you that last night I met a gentleman who had been here for many, many years, and he said to me, I said, what's the difference between, then and now? And he said, well, then was very practical. It's less practical now. I'm not sure how practical this will be to your actual clinical practice, but I do think it's very relevant to how physicians are perceived in society and what our role in society is. And I think that's very much attuned to the changing face. Very good. So, this is how I got interested. Angel Morales was sentenced to death in California. And he said, look, I don't care if you kill me, but I do care if I suffer through it. And here was his point. He said that in the last number of executions in California, it is likely or possible that the inmates were aware while they were being executed. And he said, and those of you, any anesthesiologists out here, we know that one of the worst things we can ever do is have a patient aware under anesthesia. It's a horrible experience. And Morales' argument was, I don't deserve to have this horrible experience. So a little anesthesia here. You're all very lucky to get this. In my normal practice, actually, I haven't used pentothal in about 10 years or so, but in the old days, we gave about 5 per kilo to anesthetize a patient. So a 100-kilo man, I'd give 500. And then to paralyze a patient prior to intubation, let's say, I would give 0.1 or about 10 milligrams. The California lethal injection was 5,000. That's a huge amount. Although I've had some residents try to give that. And the pancuronium, again, was a huge amount. Potassium chloride, I usually don't use this as part of my induction of anesthesia. Right? I wouldn't be standing here. But those of you who know this know that this much potassium chloride will burn like crazy and will stop the heart fairly effectively. During lethal injection, it should go like this. You receive the pentothal. You become apneic. Apneic is intended to be a surrogate for anesthetized. There's no other way when they were doing this they could know if the inmate was anesthetized. They weren't in the room, they were far away, it was dark. How they could know whether the inmate was apneic is also beyond me, but nonetheless, that was, the protocol says apnea. Then I will push the wrong button. Then he will become paralyzed. The paralyzation is purely cosmetic, so there's not a lot of movement when they receive the potassium chloride and they die. Morales' argument was too often the apnea occurred after the pancuronium or after the pancuronium and the potassium chloride. And the argument was this. Morales was not saying that these inmates were aware, but he was saying that the fact that they did not become apneic from such a massive overdose of pentothal meant that not all the pentothal, sodium thiopental, the STP, made it to the inmate, which meant that that inmate was at risk for awareness. Here are the specifics. All these cases, you will notice, have the consistent thing of the apnea occurred not after the pentothal, but after the pancuronium. And that was their argument. And we see different time periods. For example, here, they waited 2 minutes before they gave the pancuronium. Clearly not apneic here, they waited 9 minutes. But nonetheless, apnea after pancuronium, not after pentothal. So Judge Fogel said this. He said, all right, you got a point. But the state has an interest in executing you. So I'm going to give the state two options. You can use the barbiturate only, which is sodium thiopental, or you can get a qualified individual, which is, yes, thank you very much, anesthesiologist. And he actually used that word. We are going to come back to the fact that Fogel mentioned anesthesiology, because that is a very important part of this story. So here's what happened, and here's where I became interested. They found two anesthesiologists who were willing to do this. Now, because of my role in anesthesiology and ethics, I had an inside view of all this. And the ASA and the AMA put pressure, and the CSA, California Society of Anesthesiology, let's not leave them out, put pressure on these gentlemen not to participate, in part because of the AMA Code of Ethics. And so they did not participate. California has not had an execution since then, and Morales is still in jail. Now, the AMA Code of Ethics. You can't do it. Now, I know less than half the physicians in the country belong to the AMA, and I know I saw this outside. I don't know how much Utah is interested in the AMA. The top line here is the UMA, Utah Medical Association, and AMA are separate organizations. And we are not a subchapter of the AMA. So probably not the only person who has their disagreements with the AMA. So here's the outline. Is there a problem? May physicians be involved? And I'll offer you my views. There is always a tension in giving this lecture. The ethicist in me wants to go deep into all the issues, because that's what I find fun and interesting. The speaker in me wants to skim the treetops, because I have found that invariably many people in the audience want to make a comment, have questions, or so forth and so on. So this lecture is designed to go either way depending on my sense of the audience. My sense is that there'll be a lot of comments afterwards, so I'm going to skim. And then if you want me to expand on any issues, please do. Please, this is not about that. Remember earlier I said I don't know about cars? I don't know about the legitimacy of capital punishment. I have my own views, which I keep private, but I have not studied this to the length I've studied other things, and so I do not offer an opinion on that. This slide will actually repeat at the end as a reminder. All right, let's look at some of the errors we've had. John Wayne Gacy, they had a machine. The pentothal and pancuronium precipitated. Now, I started my anesthesia residency in 1989. The first week of anesthesia residency, you learn that this precipitates. And so for them to say, who knew, it's absurd, because basically if you made that mistake after your first week of anesthesia residency, your attending was not very happy. Emmett Foster, Missouri, one of my hometowns. Love this one. What happened was the restraint was acting as a tourniquet. So the coroner, they're sitting there looking at the guy, he's looking at them, nothing's happening. Finally, they realize what's going on. They loosen the restraint. Everything rushes in, he dies. The fact that he was pronounced dead 6 minutes later is actually very consistent with the fact that he died right away, because most states wait 5 minutes of an absence of a heartbeat before they will declare death. If this happened this way, there's no way the pentothal and the pancuronium worked quickly enough, which meant that Mr. Foster had that sensation of incredible burning in his arm and awareness of his death. Sheriff's office, whatever. This is another one of my concerns, which is that the goal of the state is to create death. The goal of the state is not necessarily to have a humane death. Some people care about that. Some people don't. My personal favorite, Joe Clark, Ohio. Big guy, 400 pounds. Put an IV in him. They inject medication. He falls asleep for about 3 minutes. Cleans up. It don't work. I wish I'd been there. So they spend another half hour or so getting access. They hook the IV line up to the old IV. Clark says, that's the wrong IV. And so he tells them to hook it up to the working IV. You can't make this stuff up. He injects the chemicals. Something is still wrong because he's not apneic for another 13 minutes. And witnesses say he repeatedly lifts his head as if he's trying to speak. Finally, he has a good graces to die and stop the penitentiary's embarrassment. Angel Diaz. This was the one that really galvanized this whole discussion in society, because the Florida governor declared a moratorium after this event. Diaz had 2 IVs, and they injected in both arms. 24 minutes after injections, Diaz was grimacing, blinking, licking his lips, and attempting to mouth words. He was flopping like a dead fish. My anesthesiologist colleague, what happened? You know? When do we see patients flop? When they are partially paralyzed. So what happened was both IVs extravasated into the soft tissue. He had chemical burns on both arms, and the pancuronium, the muscle relaxant, was being slowly absorbed back in until it finally reached to the extent that he died. A lot of problems in capital punishment. Now first, let me say, and I'll come back to this again, we only know about 5% of the 900 executions since 2001. And what we know comes not from the courts, not from the actual practice, except for California for those 5 cases. What we know is from observers watching outside. So our data is shoddy at best. But here's what we do know from court cases. Preparation of chemicals, poorly done. It's hard actually to mix up pentothal correctly. It doesn't dissolve that well, and people who do it, infrequently are not very good at it. Therefore, as what probably happened in California, it was too light. It wasn't the 5,000 milligrams. It was less because it was too diluted. Or they left the sediment on the bottom of the bottle. In fact, one of the things in Missouri was they had a dyslexic surgeon who was their executioner, and they found out later that because of his dyslexia, he was mixing up the chemicals wrong. I will comment that we actually don't know who does the vast majority of executions because states are not forthcoming. And So while we do know that some physicians do it, it's more likely that EMTs or penitentiary personnel, prison personnel do it. Don't know what that means. Use of a paralytic, what Morales was concerned about, which is I'm going to be paralyzed and I'm going to be awake. Inability to assess consciousness and pain. So in theory, you give the sodium thiopental to induce anesthesia. You assess to make sure they're anesthetized, and then you give a muscle relaxant. This is what I do quite frequently every day. The people doing this were untrained in how to assess anesthetic depth, were physically not in the room, and were doing it from 30 feet away, 20 feet away, and the execution took place in a dark chamber. So I have no idea how they could do this. And I theoretically have been trained in it. The protocols are awful because if the inmate is not dead, give more muscle relaxant, give more potassium chloride, but they don't say give more anesthetic. Although later revisions, the last year or so, those revisions include giving more anesthetic. There's no observation of what's happening and there's no quality control. So we don't know when they deviate from protocol. We don't know if they know when they deviate from protocol. It's very interesting in court cases, the wardens say our protocol is this, but when you actually look at the protocol, it doesn't say that. Who knows? So it's impossible to know how well they are preparing for it. And there are no records, and no one wants to share. And clearly there's no plan if unable to obtain venous access, which is a common occurrence. Now we come to Bays. Bays was a gentleman from Kentucky who said, look, you can kill me, that's great, don't want to be aware. In my opinion, just from a strategic point of view, not to tell you what I think, but just if our strategizing, Bays blew it. He blew it because their case focused solely on the muscle relaxant and on being aware. That was easily defeated, and he should have focused in other areas, which many on the slide I just showed you. Nonetheless, Justice Roberts wrote the lead opinion with only 2 other judges concurring, an incredibly fragmented court. If you ever have a chance, you should look up Justice Clarence Thomas's opinion. Fascinating. He reviews the history of how people were put to death from the 1400s, and it's rather gory. But Justice Roberts said this: if it's done right, there's no harm to the inmate. And I think we would all agree with that. And then he said, well, all right, when I say no harm, I'm talking about suffering, not talking about death. But then he said the same argument my almost 14-year-old daughter says to me. Dad, everyone else is doing it. And that was her argument. It's the ipso facto standard. That means it's fine. Which, while I find stunning, talking to lawyers, oh yeah, that's a legitimate argument. Everyone else does it, Dad. I put a lot of text on here because I wanted you to be able to see what the court said, but I'll sum it up for you. One of Bays' arguments was putting me through this violates the Eighth Amendment, cruel and unusual punishment. The court said no. Because that is if you intend to inflict pain. If you don't intend to inflict pain, if it happens, again, I think much like my daughter to her parents, it doesn't count as the Eighth Amendment. Furthermore, Roberts said this: if it does, however, rise to the level where we can predict a high likelihood of harm to the inmate, then we need to think about it. Because then it may rise to that level because we know with some likelihood that it will cause harm. But he went on to say, look, the state has an interest in making sure capital punishment happens. Again, whatever your belief, is part of our code of laws, and if you believe in it, you believe it has a positive effect on society. And so he says, but even if this does rise to that level of deliberate harm, you got to give me an alternate plan that's better, because I can't get rid of this plan until you give me a new one. And until that new plan's out there, then and only then can I say that the other plan is a violation of the Eighth Amendment. So if you were against the death penalty, devastating ruling. Because this was the first time the Supreme Court said 3-drug protocol is fine. If you were in favor of capital punishment, great ruling. You're off to the races. But as we know, states don't like to be sued. Makes sense to me. So Ohio, in this fall and winter, looked at what Fogel said and said, you know what we're going to do? We're going to the single drug technique. We're just going to give sodium thiopental. And they've done it by accounts 3 times without known problems. Again, the quality of these data are unknown. However, this is being adopted by others. Washington State is in the process of adopting this. Pennsylvania is kicking it around. I don't think they're going to get out of this. I think they're going to temporize legal challenges, but I think the possibility of errors are still so great that they're still going to be sued, one way or another. But we'll have to wait and see on that. Because again, no data. Hard to make a case, hard to meet the first rule of Roberts, which is show me there's a high likelihood of harm. To even get to the second rule of got a better plan? Let's hear it. This is pretty straightforward. And I think you could put ICU nurses, anyone trained in management of intravenous access, placement, ensuring that it's actually working well, assessing anesthetic depth, the ability to respond to problems. We're going to get into the ethical part of this. So far what I've given you is predominantly fact. The events that are reported are accepted by everyone. AMA opinion again. We don't care what people think about capital punishment, but you can't play. This was their first opinion written in 1980, most recently updated in 1993. Now here's what they prohibit, and this is what's interesting. You can't choose an IV site. You can't start an IV line. You can't prescribe, prepare, administer, supervise injections, doses, or types. These are big areas where errors happen. You can't work on maintaining devices, and you can't consult with or supervise personnel. That's actually a very interesting one, because it's unclear whether that prohibits participating in a panel to try to design more effective methods, or if they mean this inmate right here. It's very relevant to me as an anesthesiologist, because my board, the board that certifies me, has said, guess what, guys? You violate the AMA rules, you can be decertified. Your diplomat status can be withdrawn. Now, while technically I can practice without being a diplomat, functionally, all the hospitals I work in require you to be a diplomat. Functionally, state medical boards are kind of interested if you're not a diplomat, and are really interested if you were a diplomat and you're not a diplomat now. And he makes, actually a very good friend of mine, Mark Rockoff, who's on the ABA board, makes 2 points about this. He's worried that patients should confuse the practice of anesthesiology with the injection of drugs which cause death. And admittedly, lethal injection mimics an anesthesia induction. Maybe different drugs now, but it's the same process. I have a little more respect for the American public than that, and I think that distinction is fairly obvious. However, I think his second point is a good one. Going back to the Fogel case, find someone who's anesthesia trained. We are at risk of being chosen, we being anesthesiologists. We are at risk of being labeled the executioners. And I think the ABA has a very legitimate point in saying too high of a risk for anesthesiologists. We're not going to comment on other specialties because, well, other specialties can decide for themselves. What's interesting about this is while the American Medical Association and the similar organizations for nursing, for paramedics, for EMTs, and so forth, have all said, you can't participate, they have no teeth. This is the first board that actually has teeth, that can actually say, you can't do that. In fact, this is the first board that threatens to revoke your diplomat status for a wholly legal action. All the other boards talk about felonies and so forth, and I think rings pretty true to us. As an aside, while I fully get the risk of being chosen, and I think that's a fairly legitimate argument, I do have reservations about any medical board prohibiting wholly legal action and doing social engineering. Because, yeah, when you're the guy in charge or when they're doing what you like, social engineering is great. But if you're not the guy in charge, if you don't like what they're doing, social engineering has its problems. And we're really starting a slope here. Talk about two main arguments. May I, and what are the harms? On this side is one set of arguments, on here is the other set. I will do my best to give both its most powerful weight. First argument is physicians do not cause death. Utterly clear, utterly simple, utterly black and white. And we never want to be associated with causing death. The first rejoinder to that is simple. Any of you who work in the ICU, we let people die. Sometimes we're the proximate cause. We withdraw therapy. Stop epinephrine. Extubate the patient, so forth and so on. This causes people to die. And in fact, in Oregon, a patient who is not at immediate risk for death can choose to go to their physician, say, yeah, I'm done. The cancer's hurting me too much, or most commonly, in terms of percent of disease, ALS is becoming too hard to manage. I want you to write me a script to kill myself. Wholly legal, about 30 a year, hasn't been a problem so far. The Netherlands has been doing this publicly for about 20 years. Both the physician aid in dying, which is what's in Oregon, and active euthanasia, where they walk up and inject a medication. And the Netherlands has said you will not be prosecuted for this if you fulfill certain requirements. So, again, the people who are against physician participation say, yeah, but the death of the inmate is not inevitable. The death of the inmate is involuntary. Right? We withdrew care on my father about 1.5 years ago after a massive stroke. His MRI was awful. He was non-communicative. He was moaning in pain constantly. And we withdrew food and fluid because he was suffering. And it's easy to make a risk-benefit argument to withdraw care on my father in that case. But to the inmate, it's hard to do. Finally, we don't want to be a tool of government. I want to focus on these arguments a little bit. Is it inevitable? Clearly, the inmate is not going to die anytime soon, but for the death penalty. And for the most part, inmates don't choose to be put to death by the death penalty. Those who would say physicians can participate would say, yeah, but you know what? Death is going to happen anyway. However, it's going to happen whether it's because of a massive stroke like my father, or is it because state sanctioned. Furthermore, they would say, there's no difference to the inmate. He's going to die. And I say he because very few women have been put to death, although some have. So this argument is, hey, they're going to die anyway. Well, the rejoinder to that is, wasn't that the Nazi doctor's argument, which is really not who you want to refer to or use as your basis of an ethical argument? It's kind of poor. This argument, not a big fan of. And I think it disrespects the extent of evil and bizarreness of Nazi Germany. But let's walk through this anyway, because it's important to be able to reject this argument. There are other arguments against physician participation that I like, but this is not one of them. Germany was a fascist society where the sole goal was the Volk, the society. And they thought of killing as therapeutic, for the same way as if I had a pneumonia, you would give me antibiotics to kill those little bacteria guys in there. Or, if it was appropriate, you would amputate my foot to prevent harm to the rest of my body. They viewed, for the good of the Volk, for the good of the state, pruning the weak and pruning undesirables. Gypsies, religious personnel, Jews, you know the drill. I'm going to argue that's not true today in our society. We are not a totally free society, but a pretty much free society. I can say almost whatever I want in public as long as I'm not putting you at risk. I can turn on Fox, NBC, CNN, and hear three completely different takes on the same story. Of course, I don't know what the truth is. I know which one I find most entertaining. Furthermore, we have public lawmaking, right? I mean, our lawmaking, for the most part, is in public. I can vote, and I can choose who I want to represent me at both local levels and national levels. But also as a society, we're different. So I've been challenged on this with the Obama presidency because, and I'm going to try to hide any feelings I have about that. I don't want to talk about that. But some people perceive a loss of individualism, trending towards socialism with the Obama presidency. That being said, we still as a society prioritize the individual more than than European countries by far. So I want to emphasize that. Finally, our actions in this case, I'm presenting to you, are altruistic. I'm trying to help the guy. Tool of government, very powerful argument. The main argument. We should be cautious about doing things for the government that are not healthcare related, because that leads to abuses. And it uses our informal authority or our ability to know about patients and know about their lives to do things. When we do participate with the government, there's a clear greater good. So when we quarantine an area, yes, I'm restricting an individual's freedom, but I'm doing it for the greater good. And we can see that. Or triage. And the argument here is that the state wants capital punishment, fine. It's not medicine's problem. You deal with it. We're not here to solve your problem. This is not a medical procedure. This is a non-healthcare matter. You deal with it. I think Bob Trug makes a really strong point about the risk of physicians working for the government in non-healthcare matters. This is also, I think, a very strong argument, which is, I believe, the inmate's request is wholly legitimate. If I were being put to death, I don't want to suffer. Clearly. And if it's going to happen that I'm being put to death, I want to find the best person I can to do this. The fact that the government's goals of causing death and the inmate's goals of causing a pain-free death are in alignment is irrelevant. And as I will later tell you, one can take this idea and sort of develop a physician-patient relationship with the inmate. I want you to think about this idea a little more because this is a powerful argument. John Rawls presented a concept called the veil of ignorance. Veil of ignorance goes like this. Design a society, but the society you design, you don't know who you're going to be in it. You're going to be the smartest person, you're going to be the dumbest person, you're going to be the most athletic person, you're going to be the least athletic person, you're going to be the healthiest person, you're going to be the unhealthiest person. If that were the case, this is a very powerful argument. And if you don't buy this one, sometimes I change it to, if it were your son. People often say, but what about executing the falsely convicted? I say, in this argument, who better? Who more deserves a pain-free death? But everyone deserves a pain-free death by this argument. Those are the two arguments that we need to focus on. There are a ton of other arguments which I think are relatively meaningless, but for completeness' sake, I need to talk about them. Slippery slope arguments. Doing A makes B easier to do. A good slippery slope is detailed and modest. So the psychological slippery slope argument here is, well, if we let physicians do this, we're going to end up like the Nazis. A guy named John Burgess calls this the one big argument in a mocking manner because he wants to know what all this hand waving is in here. He says it needs to be detailed, it needs to be modest. In no other time do we accept such a sloppy argument. Furthermore, he argues that when he says, well, give me details, they say, no, we don't want to give you details, but you give us details back about how this is not going to happen. This is irrelevant. Until it's narrow and small, you can't make the foot in the door argument. And, analogy is Nazi Germany, Chinese psychiatry, where they're used basically to put away people who fight the government. Back to the Nazis. Will this hurt physicians? So Robert J. Lifton, probably the foremost scholar on Nazi medicine, studied what happened to Nazi physicians and Nazi people who were in concentration camps and so forth. And what he found was that these people were able to split themselves, compartmentalize, where one part, go home, pet the dog, play with the kids, be sad about their dog dying, and the other part, commit whatever atrocity you want. And he said, through this, evil can happen. And that's one of the concerns. Will we create physicians who can compartmentalize and cause evil? So Osofsky did a study in some southern jails. He said, let me look at the execution teams. And what he found out was, after about 5 executions, these hospital personnel, these prison personnel began to justify what they were doing. They would justify cutting corners because these are bad people anyway. Who cares? Because, you know what? This is how I make my money. And if I don't do this, I might not have a job. And they become totally desensitized to the inmate. Not too sure what to do with that study. It doesn't talk about psychiatric or psychological interventions. Again, dearth of mental health. It doesn't talk about what the application is to physicians. It doesn't talk about what if you limit the number. Don't know how that argument plays into it. Another argument. If Nazi doctors had held the line in the late 30s, all the atrocities that happened in the later 30s and 40s wouldn't have happened. And they focused on what was called the T4 program. The T4 program, mid-30s, they took people who were developmentally delayed, drains on society, useless people in society. They took the old and infirmed, took them away, and killed them. And that's actually where they developed their techniques of how to kill. They went through, if you read this, it's quite interesting how they go through a number of iterations of how to do this efficiently. So the argument is, if doctors had stood up then, the rest wouldn't have happened. And they point to the fact that 45% of the doctors joined the Nazi Party, much less than some of their other colleagues. Again, not an argument I'm a fan of. What really happened was the number of Nazi doctors increased after 1937 when they kicked out all the undesirable doctors. And the people who went in were people looking to advance. And this is fairly well accepted. And so the physicians followed society, and the physicians who were involved were looking for personal benefit. The way you advance is you join the Nazi Party. Okay, so if we're going to do this, people do this, it's easier for me to do other bad things. First of all, how many physicians are actually doing this? I mean, is it really that widespread? No. 60 executions a year, 80 executions a year. So it wouldn't be that widespread where all these physicians would harm. Furthermore, we know that in Oregon, so far, there have been no known abuses. And Oregon's very tightly studied. Maybe that's why there are no abuses. So there's not been a slippery slope there. However, in the Netherlands, they do a big study about every 5 or 6 years to look at what's been happening. There are clearly abuses. Very small number, but there are some involuntary euthanasia. That is, I didn't raise my hand and say I'm ready to die. We think it's the right thing to do. And some euthanasia of infants. So maybe there's something there. I'm not sure. Eugenics. There is something to say about our society as an ability to correct. We may go a little bit to the left, we may go a little bit to the right, but we kind of nudge back to the middle. In the 1920s, the Germans complained that the United States was well ahead of them in terms of eugenics. We were winning the race. And our society said, you know what? That's wrong. Society pulled back from that. By the way, another theory about why our society pulled back, one which doesn't support this argument, is that since the Nazis were heavily involved in eugenics, we didn't want to be associated with them. I think that's more of a secondary, lower theory, but I should, for fairness, say that. All right. Oh, it's going to harm trust. Really? First of all, the previous speaker spoke about how all of these drug studies are misleading. We have the Vioxx study. As a former user of Vioxx, this isn't good. The breast cancer trials, where the Canadian surgeon made up a number of cases and therefore had to recalculate the whole study about what to recommend women when a lump is found. You really want to talk about a more emotional subject? Sunbeam. Oh, hi, we're the AMA. Give us a lot of money. We'll put our stamp on your stuff, even if we're not actually examining it, see if it's any good. And then the AMA had to buy the way out of it. Tuskegee, really? Insurance, really? My argument is not that because we did these bad things, you can do other bad things. My argument in this argument is that any harm from permitting physician participation can't really be much worse than the harm caused by these events and others. And in fact, we've weathered these events and others. So you can't make the claim that the harm to trust is going to be that bad. Finally, palatability. It's a Trojan horse. if physicians do not participate, capital punishment will become less palatable because it will be ugly. And the state throughout the years, from Dr. Guillotine, who proposed using a guillotine, to now, have been pushing the idea of having pretty executions. I don't like this argument because I don't think it's an effective approach. And therefore, if your goal is to minimize harm to inmates, this will not do it. And I think this is more of a sham argument. Once again, really want to emphasize this. Not here to talk about this. I'm not an expert in it. So the two main arguments I think are worth really focusing on are con, physicians cannot be a tool for the government in non-healthcare matters. Really dangerous. Pro, we know that inmates are suffering. There are real tangible benefits right now. My view, clearly, is I favor the real benefits. Here's what you've got to do. Now I'm changing and speaking in favor of permitting physician participation, just to be clear, my view. One, you can change it away from the medical. So, officer and a gentleman, you all familiar with this? Remember we're in the chamber where they deprive the people of oxygen? And when I was in the Air Force, I got to go through this. Depriving people of oxygen is a lot of fun. You get giddy. You start laughing. It would actually be an incredibly pleasant way to die. So if you want to remove the physicians from the discussion, you got to move away from the medical. Or, hey, let's learn about the other 95% of the cases. And let's study what Ohio is doing with the purely one drug, the pentothal approach. As Roberts said earlier, as I said earlier about Roberts, if you can prove it will cause a predictable harm, then it may violate the Eighth Amendment, cruel and unusual punishment. You know, as someone who also does safety and quality, I wish Intermountain was in charge of this because they could find this out very quickly. I am in no way suggesting Intermountain get into the process of studying capital punishment. All right, my view here: should there be a carve-out for anesthesiologists? I think the ABA, American Board of Anesthesiology, makes a strong argument for that, because anesthesiologists in particular are at risk for being labeled executioners because the current way of lethal injection is so similar to anesthesiology. How do I define participation? I would say the whole thing. Ideally, I would like to suggest other ways of doing it. Now, whether I run into a problem with that last codicil on the AMA rules about not participating in or consultating in development, I don't know. And as someone who needs to be certified, I worry about that. But I would say, if another physician wants to do it, I would support them in any way they want. Let me conceptualize this for you. I view it as an altruistic practice in medicine, where I have a relationship with the inmate who is now my patient. Therefore, the patient has to ask my involvement. I need to be licensed in that state. It's actually pretty nice because I'm only licensed in Massachusetts, so I couldn't be called to task for doing this. If you do it, you have to undergo counseling. We have to study this and see what happens. And the government can't demand it. It must be an altruistic action of the physician. This is my don't blame anybody else but me slide. So thank you. What comments do y'all have? I'll pay you later. I tried to end early for that reason. Sir?
I have previously felt it was completely unethical for a physician to participate in an execution. You kind of got me to thinking, though, when you suggested that the inmate might come to me and request my services to prevent suffering. And that's the first argument I've heard that makes me think again that maybe under some circumstances this might be ethical. I feel that my job is to work for the benefit of my patient. If I am working for the benefit of the inmate at his request, that seems to put a slightly different slant on it.
Obviously, I agree that the other benefit, which is as the inmate's physician, I'm solely there to minimize suffering. I am not there to achieve the state's interest of death.
It's tricky.
Well, of course, ethicists like tricky stuff. Sir?
So in general, I have to say I kind of agree with your perspective. However, it seems to me there's the easier solution here. Our right to prescribe medications in a society is given by the government. Our right to practice medicine is certified by professional societies. It seems just as we allow medics to perform basic operations out on the military field, the government has the right to create a novel field of executioners who could be fully trained in maybe even only 3 to 6 months to be executioners with compassion. And the medical creep into society is itself an argument to say, no, let's just professionalize this as something outside of medicine.
The concern about that is that the AMA prohibits training these individuals. So somebody in medicine would need to, medicine, nursing, so forth, professional capacity, would need to train these people. But other than that, that's a great idea.
The government can say, AMA, that's very nice, but I'm going to hire this other person from Europe to train. It's a trivial argument, right? I mean,
wow, that's pretty slick. You might want to call the gentleman who's due to be shot next month in Utah and see if he's changing his mind. Sir?
Speaking of that, I can tell you the minute I changed my mind on capital punishment, I was at Knott's Berry Farm and watching the glassblower do his work. And this was at the time Gary Gilmore was about to be executed. He always asks people, which state are you from? And I told him, I'm from Utah. He said, well, what about this Gilmore fellow? Do you think they should put him to death or not? I said, oh, yeah, I believe in capital punishment. He's killed 2 people. He deserves to die. Next question was, would you be willing to pull the trigger? And I said, well, maybe not. His question was, then you don't really believe in capital punishment, do you? And that's my thought about it, is that maybe we should avoid it altogether. Thank you.
I will continue with my declaration of not speaking about capital punishment per se.
As I think about this, does a physician participation differ based on what the method of execution is? So if your physician's a good marksman here in Utah, what do you think?
So if you read the American Board of Anesthesiologists statement closely, it says, participate in a legally authorized execution. So that would include that, although the AMA specifically talks about lethal injection. I think in that case, you're not acting in that role as a physician. It would be fine. One thing about the ABA statement is a legally authorized execution. So can I participate in an illegal execution? Is that... William Sapphire's my idol, so I like to pick that apart a bit. Sir?
How do you feel like this relates to the abortion issue and medicine?
Really?
Because some people would say, hey, I can see both sides of that argument where you'd say, in that we have somehow committed ourselves to a somewhat slippery slope in medicine. where physicians may be comfortable performing certain abortions but not others at the same time.
So abortion is a terrific analogy here, isn't it?
Yeah.
And I've steadfastly avoided it because you would pour more oil on the fire, really? I mean, it's very hard to have a reasoned argument when you include abortion because people have such strong feelings about it on both sides of the fence. I will comment, though, that I find an interesting divide between people who favor, all right, I want to try to do this politically correct, and I won't, so I apologize if I botch the political correctness. People who are pro-choice are opposed to capital punishment. People who are in favor of capital punishment tend to be pro-life. And the first group are steadfastly against physician participation. And the second group tend to be much more comfortable with it in terms of, well, if that makes it more efficient, great, let's do it, if that solves the court problems. The consistency there I find tough to follow. Sir?
So have most of the executions in the U.S. been done by non-physicians?
We don't know, because we only know about 5% of the executions. The rest are, excuse the pun, shrouded, and so we don't know. We do know that Texas and Georgia state they use prison personnel, and they don't have physicians as prison personnel precisely. They consult out to physicians to come in and do medical care. Whether that's an indicator, it's hard to say.
Have any physicians owned up to it, and have they suffered any consequences, either legally, medical society-wise, psychologically, whatever?
So Atul Gawande had an article in the New England Journal several years ago where he found 5 physicians who were doing this. And some had done it and stopped, others hadn't. At that report, they had found this gentleman reported no harm. I personally would want to be anonymous, and they all wanted to be anonymous, because in our society, I would worry that, well, if I executed your brother, your father, you would come after me. So I think their desire for anonymity is quite reasonable. Sir? That doesn't mean we couldn't know their role, right? Physician, nurse, EMT. Sir?
Who pronounces these executed people dead?
Very precisely done. Very well orchestrated. The tech comes in after either 2 or 5 minutes of asystole, either by an EKG monitor or by pulse. And then a coroner is brought in to agree or disagree. And then the physician comes in, who has been in a physically separate room, presumably reading a magazine, to pronounce the person dead. And that the AMA is okay with.
The state does have an interest in killing people. We go to war all the time. Doctors support war efforts. Doctors support the soldiers who are going to be healed up and go out and kill. So the state has a legitimate interest in killing people, pretty much as a universally accepted standard of statehood. And the policing process of killing criminals is along the same lines. So there's kind of a hand-waving argument saying that doctors don't participate in this kind of a thing. And along the lines of, well, we can kill people, but I don't want to shoot them myself. We do. And in a philosophical and very fundamental way, we do.
And as someone who was in the first Gulf War, where I spent a lot of time playing volleyball in the sand and doing nothing for the first 6 months, it was brutally boring. I had no qualms with that. If someone attacked me, I would have tried to shoot him. My aim might not be as good as y'all in Utah, but I would have tried.
I thought a lot of this was settled when we took the Hippocratic Oath. I took it seriously.
What's interesting about the Hippocratic Oath is it says a lot of other things. It says we shan't do surgery. Well, obviously we do. The reason he said that was because surgery back then was done by charlatans, and so we shan't participate with them. Other writings by Hippocrates, which are consistent with that, say things like, lie to your patient and tell them they're going to get better, because quite frankly, really they didn't have much to offer. So that was positive feelings. It also said, as I remind my trainees, the student should share half his salary with the teacher. But I think you make a powerful argument that many of us entered medicine to help people. And this argument is really centered on the idea of, as one gentleman said, helping the inmate. So, ma'am?
One of the things you mentioned earlier was dying from hypoxia, being placed in a hypobaric chamber. Patient experiences a little bit of, not patient, the inmate would experience some euphoria. There would be a lot fewer botch-ups. There are lots of hypobaric chambers around the country. Has anybody ever given that some thought?
Did you see that slide about the American Board of Anesthesiology? No. The legitimate question is, I threw that out there because someone once mentioned that to me, and I thought, to point out there are alternatives. Shooting, throwing off a bridge, so forth, so on. And I just find that one captivates the audience a little more. I don't know if that or any other ideas have been formally discussed, considered, so forth, so on. But most people have seen Officer and a Gentleman, so they have that image. They remember that part. Sir?
I don't understand how you come to the conclusion that you can participate in this and not be a tool of the government. Explain to me.
Great question, and it's the strongest weakness. It is the biggest weakness of the argument, and I'm doing it based on intent. I'm doing it based on what my view is as the physician doing it, and what my intent is, which is better care of the inmate. Many people think that's sleight of hand, and I think, as you would argue, but you're just really splitting hairs. I think that's a valid objection. We got follow-up, sir?
Just to make one comment. I'm the director of the Hyperbaric Center here in Ogden. I don't want to be involved with this. Thanks so much for volunteering.
Yes, but with the current economic crisis, will you rent it out?
Well, people are talking that we shouldn't be involved with the government, but I've been a long time a government employee asked to do things that like killing and moving people, and I've been in the military, so they told me, and I obeyed. But I think that the government has a right, and probably we as physicians who have joined the military or joined the public health services and a lot of other services, why we do what the government says.
And I agree, the military and public health service have a definite carve out. As someone who's in the Air Force, which is, those of you who are not quite the military, no Army and Navy guys out there, huh? But I think that's a very legitimate concern. I think the counter argument would be those are in certain areas which are not as egregious as capital punishment. Sir?
Just kind of a follow-up question. If your state allowed capital punishment, would you participate?
I don't know. And no, I'm being honest, because I've never had to face that. I would like to think I would. Oh, okay. I would like to think I have if this is what I think, I should do it. I don't think that you have to be able to do it if you believe in the argument I'm setting forth. I don't, as your glass blower made that argument, I don't buy that. But I think I'd like to think I could. Sir?
I'm an anesthesiologist, retired after 50 years. I have many patients when I come and see them pre-op that say, oh, you're the guy that's going to put me to sleep, or you're the guy that makes sure I stay alive. I would hate to have anesthesiologists nowadays come in the pre-op areas and say, oh, you're the executioner that's going to take care of me, huh?
But do you think patients would actually be confused as to what your role is on that day? No, I'm asking seriously.
I think they might be kidding, but I think a lot of them would get that idea. The other thing is, why not just train somebody in the criminal area to learn how to do IVs, not in the area of execution, but just somewhere in a room in the jail or the penitentiary where the one person, perhaps, or two persons, to keep it anonymous, could learn to do IVs very, very correctly and adequately, and make sure that there isn't any problem of these patients getting the drugs, because the dosages are adequate to kill if they're given right.
To the gentleman's first point, that the concern about the patient is the ABA's strong concern, and so many people agree with you about that. The second point, as I mentioned, the people who would have to train him would have to be skilled in it, who would be involved in the medical profession, becomes dicey. Sir?
I had a patient, 33-year-old woman with far advanced breast cancer back in the 60s. We had very little to treat breast cancer with at that time. And making rounds one night, she asked me if I would pray that she could die. And I thought about that a long time. Made rounds, came back, and discussed it, and I did pray that she could die. I went home, and 2 hours later the hospital called me and said she died. I considered that spiritual euthanasia, and I didn't cause the death. I blamed it on God.
It's interesting, going back to my father, he was diagnosed with liver cancer, and he recovered. This is a good 5 or 6 years before he died. But early on I had a discussion with him. I said, Dad, let me tell you about liver cancer, let me tell you what's going to happen. If the pain ever gets too much, and you don't want to be here anymore, I told him I'd help him with it. Because he's my dad, and I love him, and I don't, obviously I'd try to help him manage pain first, but I mean, if we ever reached the point where it was too much, there is a role for that. Sir?
So would it change the equation next week or month or whenever this guy's going to the firing squad if a physician ahead of time gave him pain medication so that he would not suffer?
So the AMA says it is permissible for psychiatrists to give sedatives, anxiolytics prior to the execution. So I kind of think that would fall in accordance with that. Fine. Thank you. That was excellent. Very good.